Hello, good morning. It's really nice to be here, and I'd like to thank the Victorian Council on Social Services, the Council to Homeless Persons, RMIT, and Melbourne U for the chance to speak here today. As she mentioned, I'm a physician in the U.S. Department of Veterans Affairs and faculty member at the University of Alabama at Birmingham. There are a number of disclosures. I don't have a commercial interest here. My statements don't represent positions of the United States government or the state of Alabama, et cetera, et cetera. And the work here, the research, a good amount of it was funded by United States federal funders, including the Department of Veterans Affairs. I want you to know where I'm from. I'm from Birmingham, Alabama. And this is a view from a mountaintop that looks down on it. It's historically an iron city. Birmingham is famous for some of the most difficult moments in the United States history of the 20th century, most importantly, the fight for civil rights and the desegregation of the Old South. This is one of those most terrible pictures of police using dogs to confront a young protester. And it's important to say that a city like Birmingham has recognized and struggled greatly with that history and put it on display in remarkable ways. And it's a very intimate part of life in Birmingham. This is a talk that really, as you're going to see, comes from both the head and from the heart. From the heart, I am passionately committed to working to end homelessness and to working to Alabama has some other remarkable parts to be known. We have an extraordinary rocket industry, which played a big role in the United States space program, extraordinary natural beauty, and we have homelessness, although this picture is stolen from Martha Burke, the Urban Institute. We are in the middle of a paradigm shift between two approaches of responding to homelessness. One, traditionally labeled by Ridgway the linear approach, which looked at a set of stepwise recovery programs that would help individuals who are homeless and had mental illness to sort of come off. If they could succeed in one program, they move to the next. More directive in nature. And the Housing First paradigm, just a quick show of hands, how many of you actually heard of Housing First? Okay, that's great, very easy. And then we're going to talk about that in somewhat more detail. Here are some questions for the audience. These are meant to get you thinking. So imagine the following, which is relatively close to a community I know. Our housing program offers permanent supportive housing and services for chronically homeless persons who can demonstrate sobriety for 6 months. Is this a Housing First approach? How many people say yes? Raise your hand. Okay, how many people say no? Raise your hand. Okay, all hands went up, or most many. And how many said, oh, sort of yes? I missed the middle. How many said it's sort of yes? Okay, a middle number of sort of yeses. Okay, here's another, a true-false one. Research shows that offering Housing First results in an overall cost savings to society. How many believe this to be true? Raise hands, okay. Most hands went up. How many believe this to be false? Some hands went up. Okay, last interactive question, then I'll allow you to return to your slumber. What is the typical pattern of benefits identified in well-conducted Housing First research studies? Okay, better housing outcomes, improved health, and reduced overall costs. Better housing outcomes, improved health, but not reduced overall costs. Better housing outcomes only, and no better outcomes of any kind. How many are inclined to agree with A? Okay, about a quarter, a third probably. How many are inclined to agree with B? Housing and health, but not cost. Okay, about a third. Better housing only. I got a third there almost. Okay, and no better outcomes of any kind. Okay, nobody's willing to go that far. Okay, so this talks about how research informs the policy claims that we make. We're going to look particularly at studies of Housing First and cost, a little bit of a sidebar in health impact, and we're going to look at implementation. And the question is the word overreach, and I of course have to define it for purposes of this talk. Overreach is something we want to avoid. Overreach is when your claims are overclaims, or when your execution is under execution, and the result is an unhappy outcome, either in terms of the payer or the clients, or yourself. You feel unsatisfied with yourself. I chose the word because I used it in a paper I wrote 6 or 7 years now ago, Housing First for Homeless Persons with Active Addiction, Are We Overreaching, in the Millbank Quarterly. But I'm returning to some topics from that paper, but I know most of this is new information. 3 key points. If you fall asleep right after this slide, remember this. Usually Housing First tests people successfully. There are problematic public advocacy claims being made at this time, specifically in the areas of cost and health. And implementing Housing First well is a real challenge. Let's look backward. Here's one kind of response to homelessness. We certainly don't want to return to this. This is what they call the drunk tanks in the United States. Police would sort of round up the chronic public inebriates, as we call them, put them in the tank, dry them off, and let whatever happens happen after they get out. So we don't want that. Let's talk about linear approaches, which really dominated, and certainly in many places, but including the United States from this late 70s, 80s, 90s, even into the 2000s, depending on community. Rehabilitation programs make the client housing ready. That was a phrase you would see in the literature. Initial treatment would be in more supervised settings, and then people would move to less supervised settings. Clients graduate toward independence and finally into the private market or independent housing. That's a linear approach. There are many different examples of treatments that have research evidence that fit into a linear paradigm. For example, there were 4 federally funded trials from the National Institutes of Health over 15 years that looked at abstinent contingent housing, which was actually for people who were homeless and had cocaine dependence in Birmingham, Alabama, who chose to enter an addiction treatment program that had quite a bit of daytime activity. They were told, here, as soon as you enter our program, you actually get to live in an apartment for the duration of the treatment, which is 6 months. We'll be testing you randomly for drug use, probably twice a week or so. As soon as you test positive for cocaine in your urine, you'll be brought over to a homeless emergency shelter where you can stay until such time as your urine has no more cocaine in which case you return to the apartment. But throughout all this time, you can do addiction treatment during the daytime. Either way, we'll transport you to treatment. This kind of approach was studied in a sequence of trials by collaborators of mine, Jess Milby and Jeff Schumacher, proved to be very effective for reducing cocaine use, both during the time of the trial and after the trial ended. Housing did improve relative to prior to entry to the trial, as sort of pre to post comparisons. What about housing 6 months after the treatment ended? And I did look at that since I was joining their team at the end of some of these trials. I looked at their 3rd trial, which had 3 trial arms. And in the gray bar, there was the group that received addiction treatment in the daytime and abstinent contingent apartment housing. In the purple bar, housing, no abstinence required. They could also do treatment during the daytime. They were tested, but there was no consequence for the results. And the blue bar, no housing provided during treatment at all. They were in an emergency shelter, but they could come to the treatment. In fact, they were transported to it. And 6 months after treatment ended, there appeared to be differences in the outcomes of these 3 trials, with a little bit of a stronger apparent difference if you were to disregard the p-value in this comparison. But the y-axis only goes to about 40%. So most people, 6 months after the treatment ended, didn't matter which trial they were in, were not stably housed. And that's a concern. Why did that happen? Well, really, after the treatment was over, the clients were at the mercy of policymakers and housing authorities who could decide who they wanted to assist. The treatment people funded by the National Institutes of Health, they didn't have any power over long-term housing. Subsidized housing required 3 months of perfect abstinence at the time. Very few people achieve perfection when they have severe cocaine addiction. And treatment experts rarely control the housing. So we wind up at an impasse, even with evidence-based addiction treatment designed for this population. Programs worked for some, they skimmed for good clients, and then some people were left on the back page of the newspaper having died under a bridge, which is not an outcome that anybody would want. Enter the new approach, Housing First, and it has more than one sort of progenitor and father, but certainly a major power behind this from New York, Sam Samaras and others. But the approach here, a slide I borrowed from the Canadians, involves permanent supportive housing, extensive support services together. Some of the major principles here in a slide I've borrowed from Vicky Sturgiopoulos. Immediate access to housing without preconditions, consumer choice and self-determination. They make the choices about how much treatment they wish to engage in which way. They obviously can't burn down the unit, they have to be a decent tenant. But whether they do treatment programs of one kind or receive psychiatric therapies of another is up to them. They have autonomy. Recovery orientation, which is a complicated term I'll unpack later. Individualized and person-driven supports, social and community integration. Actually, the model they adopted involved scattered site apartments, so really trying to put people in the communities rather than all in one building. There have been a number of studies, including a number of randomized controlled trials of Housing First. Many are not perfect, but certainly are probably the best ever done thus far is from Canada. The Chessois team looked across 5 cities and conducted essentially 2 randomized controlled trials at once, with a lot of investment from the Canadian government. They broke the potential participants into the trial into 2 groups and then did a trial in each group. On the left-hand side of the slide, you see the high needs people, and I won't go through technical definitions, but essentially people who had typically severe mental illness, lots of institutionalization, some of the hardest to serve individuals, and they were randomly assigned to receive either housing first with assertive community treatment, meaning one individual has a team of professionals serving them while they're in an apartment, quite an intensive investment in terms of costly service, versus treatment as usual regarding whatever was available in that community. The other, somewhat less intensive group, although they certainly had mental disorders or mental conditions as well as substance use disorders, received intensive case management housing first, in which a single individual essentially brokers a variety of community-based services, working at a ratio of 16 to 1, 16 clients to 1, versus treatment as usual. And this approach proved to be quite good at housing outcomes. And these results, published in the last year or 2 in a number of journals. You see here with the intensive needs group, comparing housing first with assertive community treatment versus treatment as usual. The y-axis is the percentage of time that the individuals were housed, which is a little different from what my y-axis was in the previous slide. But you see a real difference in housing achieved. It's something quite rather large. And look at the how high the y-axis goes. It gets close to 80%. The analysis of the intermediate needs group, which was a case manager versus treatment as usual, is broken out by city. It looks like they have 4 study sites rather than 5, because there was some differences about the 5th city in the study. But again, housing first versus intensive case management, rather striking difference in housing success achieved. And this is really from the Journal of the American Medical Association, reported in 2015, a rather prominent venue for a $110 million major study from which many papers continue to emerge. And of course, even before that trial was published, the way in which the promise of housing first has been explained to the public in terms of advocacy claims has seemed extraordinarily exciting, and as I will describe, also risky. This is from Mother Jones, I would say, a leftish sort of magazine, the shockingly effective, surprisingly cheap way to fix homelessness. Vox.com, highbrow, web-based, quick policy hits by smart writers, giving housing to the homeless is 3 times cheaper than leaving them on the streets. Boy, that's a simple solution. Housing the homeless not only saves lives, it's actually cheaper than doing nothing. In Australia, we see similar kind of theme. So we have to avoid the risk of overclaim. So let's examine the claim. In 2009, I thought the cost savings arguments were overstretched and inconsistent. So how is a cost savings argument made? Let's look at how those are constructed. Very typical like this is from, actually pulled off a website of a major advocacy organization, the Denver Housing Cost Study, and there are many such studies in which people are enrolled who have been costly and challenging to serve on the streets. In Denver, there are 137 people enrolled. About 19 were actually analyzed because they had a full amount of precursor information and follow-up information, I think 2 years in either direction. And then look at the full service utilization and cost before and after the enrollment in Housing First. This is a summary slide of those results. The total dollar figures at the top show a reduction in total expenditures from pre to post. And if you look at what the breakdown is, the housing expenses go up, as you would expect since they're entering housing. But behavioral health and emergency room and healthcare, police and jail and shelter expenses go down. The overall equation is favorable, and it seems like a convincing argument. Remember, this is from Denver. The challenge is the group we call superutilizers. These studies typically look at the superutilizers, people who use a lot of hospital services. A recent analysis from Denver, the same place, found that in the healthcare system, superutilizers accounted for about 3% of the health system, although a much larger percentage of costs incurred by that system. But they often don't remain superutilizers after they are housed in pre-post studies, and they often don't remain superutilizers after doing nothing at all. You could sprinkle chocolate sauce on a lot of superutilizers, and they would stop being superutilizers. And just to demonstrate this, this is an analysis published in Health Affairs, I think a year ago. And it looks at people identified as superutilizers May 1st, 2011. Look at the far left-hand side of the slide. And it breaks them down with color coding to try to say, well, who remained a superutilizer later in time? People who are not in the original cohort of superutilizers but became superutilizers at a later time are shown as you march across the x-axis in the burgundy color. People who were in the original cohort of superutilizers but actually were destined to die during 2 years of follow-up are in orange. People who were in the original cohort of superutilizers but no longer were superutilizers at a later time are demonstrated in blue, and then gradually that percentage gets smaller and smaller. People who were in the original cohort but whose status fluctuated back and forth between being a superutilizer and not are in yellow. And finally, people who stayed superutilizers are a very, very tiny group. So we know that this is the background pattern, and this makes the pre-post studies quite problematic. So what we can say is that in an overview published last year by Lee and Latimer, shelter and emergency department costs tend to fall in a pre-post comparison as people go into housing. Hospital and jail savings have been less consistent across studies, but all the pre-post studies have this favorable finding, and then 3 of 4 studies with an experimental design show overall costs were higher with Housing First. So we'll go back to Canada's experiment. So in Housing First, the assertive community treatment trial, the cost analysis was published. Housing First with ACT cost over $22,000 Canadian per client. Both trial arms experienced a nice reduction in the cost of services that they incurred, but there weren't differences between the trial arms. And obviously, because there was some additional cost expenses incurred, the net cost of offering Housing First with assertive community treatment was a relatively small amount, but a positive, it was a positive sign next to this small number, $890. This is not this is not a vast amount. You can buy well, let's just think about it. I guess you could buy about 20 copies of the latest PlayStation 4 game for the net cost of this. So that's really a bargain as far as I'm concerned, but it's not a cost savings. Come on. There's no, in this major publication, there were no trial arm differences in some of the health outcomes that they measured, which is a concern. The intensive case management trial, the Housing First with intensive case management costed a lower figure total. It offset other expenses, but now you have a net cost to do something which I would argue is a very good thing to do, but on the order of $10,000 Canadian. Again, also they looked for differences in health outcomes and didn't find them between the 2 trial arms, except for measures of sort of community adjustment and satisfaction with their own residential situation, which I think is what you would hope to take. So my take, Housing First offsets some expenses. If one helps only very high cost persons, my guess is perhaps you could achieve some overall savings, maybe even in a randomized control trial. But we don't want to restrict this service to just people who accrue enormous amounts of cost. That would exclude lots of people who actually need the benefit of housing stability. So I think I would push us to reframe the argument toward one of pursuing an ethical objective, a valuable objective, one that's prioritized both in the United Nations Human Rights Declaration and in essentially every religious tradition that extends a preferential option to the poor and the needy. We should pursue this valuable goal, but not necessarily argue to our stakeholders that doing so necessarily advances their bottom line. It advances their ethical bottom line, but not necessarily their pecuniary bottom line. Risk number 2 to avoid is under-execution, and this will be a briefer component that looks a little bit at my own research. I'm going to be looking at the Department of Veterans Affairs. I work for the U.S. Department of Veterans Affairs. I don't view the VA as necessarily somehow the place where under-execution happened. I viewed it as the most ambitious undertaking of Housing First in the world, where we have extended 78,000, oh dear, is that me or somebody else? It's probably me. We've extended 78,000 vouchers to support the rental of veterans who are formerly homeless with congressional support. And that means there are over 150 medical centers engaged in trying to execute Housing First at the same time. That's a big undertaking, and it's a meritorious one in my view. But we want to look at the details. What happens when you try to make this happen in the real world? What if a government official says, I want this to happen, and you're not working with a $110 million funded randomized controlled trial as they were in Canada? There are challenges to high fidelity implementation. That's normal and expected with every social policy. And it's going to be more pronounced outside of clinical trials. In the literature, only 3 out of 14 Housing First trials actually assessed the fidelity to the approach called Housing First. Chez Soi, this model study, noted somewhat lower fidelity in service delivery to the individuals they were housing and actually delivering the full range of services compared to other aspects, although on whole, their fidelity was extraordinarily good. The United States Department of Veterans Affairs offers a window. Background: our former secretary, himself a former chief general of the Army, declared a goal of ending veteran homelessness. 76,000 veterans were counted as homeless per night in 2009. Congress funded 79,000 rental vouchers. Somebody's going to do the math and say that the current number of homeless must be negative 3,000. But if you were listening carefully to the prior talks, you know that homelessness is a state, not a trait. People are going in and going out, so it's not negative 3,000. It's more like 48, 49,000 who are counted homeless on a single day in January of 2015. The Veterans Affairs Department mandated that the approach be Housing First in 2012, and they were influenced significantly by Sam Simbaris, one of the originators of this approach. Our goal with VA funding was to study which parts of Housing First are most easily adopted, which parts are more difficult to adopt. What roles do leaders and staff play in executing the strategy? Our method was essentially an 8-site case study. We looked at 8 VA medical centers spread across the country, coast to coast, north to south, big city to small city. They were diverse. We conducted over 170 interviews, usually 2 or 3 of us sitting in the room. We interviewed people who ranged from front desk clerks working in the homeless programs at the local VA hospital up to the top executive of the hospital. People who were often, sometimes physicians or health administrators who were told to follow this approach but didn't necessarily know a lot about it at the beginning. And you can imagine any government agency that says we need to follow this is going to have a lot of people in the chain of command who say, well, what is it that you want us to follow? We devised some criteria for Housing First fidelity and scored performance along these criteria. And the criteria were devised through an extensive series of expert panels, which included a number of experts in Housing First. And we also visited a model program, one of those pathways to housing programs run directed by Dr. Simbaris. The first thing we realized is that when you propose to house a large number of people in private market apartments, you have a number of practical realities that have to be overcome. It really hits the road here. There are rental markets. There's disparate geographies. If an agency is in charge of 300 or 1,000 square miles of space, the people who might become homeless in rural areas and urban areas, that's a very big undertaking. There's coordination with the agencies that release the vouchers to the public. Actually, Veterans Affairs doesn't control these vouchers. It selects the clients and has to work with a different agency for them. The vouchers cover a portion of the rent, by the way, just so you understand. There are move-in funds, security deposit, paying the old utility bill from 3 years ago that you failed to pay, and if you don't pay it, they won't turn on your electricity in the new apartment. That money has to be found. There's interim sheltering of people while they undertake this bureaucracy and search. And there are clinical time issues, which is a real problem for the social workers. Are they supposed to tend to emotional issues, addiction recovery? Or are they supposed to attend to driving people around town looking for apartments? Those are in tension with each other. And mid-level managers in this system have extraordinary influence. They can adopt the principles of Housing First, with full force, or they can snow their bosses a little bit and seem to be adopting them while not actually adopting them. So you have to have extraordinary communication up and down in order for this to work. So very quick summary results. Anybody who wishes to have somewhat more detailed slides showing lots of things, I'll send more along to anybody who requests them of me, and I think we can make them available to others here. In the domains that we study at baseline and follow-up, we kind of broke 20 criteria into 5 overarching domains. Dark purple is the initial rating we gave. Lavender is the later rating that we gave at these 8 institutions. Remember, these are qualitative observations summarized into numeric scores, a little bit like how you score ice skaters at the Olympics, but we tried to be as rigorous and consensus-based process as we could. At least the judges in the Olympics don't talk with each other about what criteria they used and spend an hour on the phone discussing what it took to assign the score. So I think we're a little better than them. The notion of not imposing preconditions, this is always on a 1 to 4 score, it was really pretty strongly adopted, even though it ran contrary to the training of many of the social work staff in the Veterans Administration. The notion of rapid placement into permanent housing being a guiding value. That was relatively strongly adopted. It didn't mean that placement was always rapid, but there were lots of efforts made to smooth out the process through working groups that involved multiple agencies and assistance with housing search. Prioritization of the most vulnerable. When I defined Housing First earlier, I did not mention that as a possible criterion. Depending on the publication, sometimes you will see the notion expressed that the people who seem to be the most vulnerable, the most difficult to be housed, should in fact be the most prioritized for this program. We had a somewhat lower score for that, and we found some challenges in instituting systems to do that, and a lot of dispute. Do we prioritize a woman with children? Do we prioritize a person with multiple medical disorders? What about this person who just came back from Iraq? Aren't they all priorities? Availability of comprehensive support services. Remember what I said about the one little gap in the Fidelity analysis from the Canadian trial. We also had something of a gap there. And what I mean by that is that as the vouchers were coming in and new clients were being proposed for housing, the ratio of the number of clients per staff member serving them got less and less advantageous. So we sometimes heard from social workers saying, I am technically responsible for 40 or 50 people. I look for the crises, I respond to the crises. But I have some problems if they all have a crisis at once. And we heard from some innovative leaders trying to figure out how to rejigger the workload while waiting for new staff to come in. And I'll talk about that in a moment if we have some extra time. Finally, the notion of adopting the modern recovery philosophy. And we operationalize this principally by listening for evidence of adoption of a harm reduction philosophy and listening for the use of a motivational interviewing approach and engagement, and in prioritizing the client's own sequencing of desired recovery steps. We gave a kind of uneven score. We were not convinced that that was fully and widely understood by all, but some people were clearly very much in tune and expressed it strongly across its 8 sides. Organizationally, to make this happen, and this is particularly important for anybody here who is thinking about instituting something at a regional level or a government-initiated level. We actually applied a rigorous model of studying organizational change to the study, and I have declined to present the conceptual background of that model here, just in the service of time. But some of the lessons from how implementation was advantaged, there has to be impetus. There has to be a major shove that makes everyone feel like this has to happen. The Department of Veterans Affairs, it helped a lot that the secretary, the general with all those badges said, I want this to happen, it matters to me, and that an order was issued. Somebody needs to own it. Horizontal integration involves the collaborations across multiple agencies and departments. They can be, you might need information technology support. If you're going to house people across the community, maybe all the social workers need electronic devices to communicate readily and log into the record system from wherever they happen to be. Maybe they need additional cars. Formal cross-agency collaborative groups had to be formed, particularly to release those rental vouchers and smooth out the inevitable delays in getting somebody into an apartment paid for by a government agency. Having facilitating personnel housed with the chief executive of the medical center was something we saw. Sometimes there's a person in the chief officer of the hospital. Now, a hospital officer doesn't know much about housing, but they have someone in their office who's always filming, always checking. What problems are you having? How are the vouchers going? Do you need help? Vertical alignment looks at top to bottom, and you needed similar kinds of collaborative structures. Sometimes it can be challenging to just report to your boss, you know, what you told me to do, it's not working out. If you have an institutional work group that happens to have people from multiple layers all charged with meeting regularly to discuss the inevitable challenges that are going to come up in executing an intervention, that's a very natural place. So if the chief of the medical staff always meets with a group that includes not only a mental health chief, but a frontline clerk for mental health and a frontline housing social worker, naturally is a great forum for the expression of barriers that might require some top to bottom realignment. And these dynamics between frontline managers and agency leadership were key. So, my conclusions, and I remember I started this out saying that I try to speak from the heart and from the head, and I'm extremely attached to Housing First is what I think is a very obvious, important, and crucial tool right now to move forward in helping people escape from a devastating situation that we were not addressing satisfactorily before. Housing First is effective at housing. Net cost savings are mostly elusive, but probably achievable in a few cases. Housing First is within reach. I think there's a lot of progress, even with some limitations. A lot has been accomplished. There are thousands of people in apartments, courtesy of a national investment. How we advocate for it, how we implement it, will determine if the word overreach is applied to any of us in the future or not. And I think with that, I'd love to close and take questions, etc. Thank you for your attention.
Stefan has absolutely railed through that scintillating presentation. So we do have a few minutes for questions. So, over there.
Yes.
Hi. My name is Paul Rattrand, Centre of Applied Social Research. Just a quick question on the costings, because it was sort of a service-based comparison. And I just wondered whether you had included in that any social returns on investment, if you want to add that, and whether you had included anything in relation to people entering the employment market and paying their taxes as well, which would perhaps add a few more benefits and may prevent you having to use the term overreach as well.
So Paul asked about, first of all, I should disavow being the one who did the cost analysis. I'm quoting other people's studies. But he asks important questions. He says, hey, if there is return on investment socially, if people return to work, or if community, a particular area of town, for instance, which had lots of individuals on the streets, has fewer through this humane outcome and business improves, wouldn't that be a return on investment that would be quite substantial? And is that ever counted in the studies that I've seen? And the answer is no, it's not counted in the studies I've seen, and it could be a very important part of the equation. But you heard my rhetorical moral spin there a little bit, which was that I don't want us to argue to the people who we argue, hey, by helping homeless individuals, it will protect your wallet. I'm actually saying you're going to get some offsets, you may gain some efficiency somewhere, but most things that we try to do that are good, you have to spend a little extra to do the good thing. But I do think your points are very well taken, Paul.
Hi, and there's a special microphone.
Nicola Valentine from Launch Housing, which is a service providing organisation. Sorry, I'm going to ask if
you're good now. Nicole, yes.
Nicola Valentine, Launch Housing, which provides services to homeless people. I'm just wondering, your analysis looked largely, as I understand it, at the veterans population and at drug users. Is that right? So you're not looking at housing first across other client groups?
My own study, which was the latter part of the talk, was a study of implementation in the Department of Veterans Affairs. Yeah. There was also a smaller study for me at the beginning looking at abstinent contingent housing. But the Veterans Affairs approach would prioritize individuals who are veterans and who are homeless, and typically people who have met a United States federal definition of chronically homeless, which means that they have to have a disabling condition plus either 1 year of continuous homelessness or 4 or more episodes in 3 years. Addiction is certainly very common in that population, but it's not necessarily always the thing. In fact, there's been, it requires in some instances a real change in philosophy to retool your homeless service system to not focus on just addiction. The old systems were so addiction focused that you would run into clients. I remember this even in Boston before I entered the Veterans Administration. We said, I haven't used drugs for 5 years, but I realized I needed to get a little cocaine in my system just to get in the front door. So yes, addiction's common, but by no means was this targeting just people. The Veterans Administration initiative is just homelessness among veterans.
Yes, and so it doesn't look at women or families and the housing first approach.
The vouchers are certainly allotted to women. The vouchers are certainly allotted to women and children, and actually the guidebook implies that a strong priority should be given if one is receiving a veteran who is a woman and has a child and is unaccompanied. It's not exactly a direct order, but it's close to it. It's not a large number. The real issue sometimes is where do you house people in the interim during the search for housing if they have a child, particularly if that child's a boy over the age of 13, where sometimes family shelters can be an awkward place.
We do have to stop.
I've got to stop. Thank you so much.
Stephen just said he really enjoyed that, and I really enjoyed it, and I think it's wonderful to see someone who claims himself to be an enthusiast for housing first, but his publicity might sometimes suggest otherwise, unpack the rhetoric, unpack the good idea, and argue so strongly for model fidelity and for a clear understanding of the variables that are actually vital in getting the outcomes going forward. And I think that's certainly a study that many of us, a set of studies we'll be able to look to in the future as we evaluate our own efforts here with Housing First in Australia.